All right. Hi, everyone. I'm Tori, Senior Client Support Specialist with CE Zoom. And of course, we have a wonderful webinar for you tonight. Before we begin, I'm just going to run through a few housekeeping items as people start to roll in. First and foremost, you'll notice a chat box to the right of your screen. Feel free to use that to talk among your fellow attendees, make any comments about the presentation. We'll monitor that chat box the entire time. At the conclusion of tonight's course, we will have a Q&A session with the speakers, so please feel free to use that Q&A box at the bottom to ask any of those questions. At the conclusion of the course, we'll also have a verification code, which is very important if you want to get your CE for tonight. So in order to get your CE, write down that code, take a screenshot, whatever you need, and return to your CE Zoom account, log in and find tonight's course. There will be an arrow next to my scheduled courses. This course title will be there with a green verify button at that time. All you have to do is enter the verification code, take the mandatory course evaluations, and then your CE will be right in your account under Records Manage CE. And of course, if you have any issues with that process, you can always reach out to us at CEZoom at help@cezoom.com. And I know a lot of you are trickling in right now, so I will make a comment about that at the conclusion, as well as put some notes in the chat box for you. But for now, I'd like to introduce everyone to Brian from Synergy Dental Partners. Hi, Brian.
Hey, Tori. Good to see you again. Thank you. So good evening. I'm excited to be here tonight. So I'm Brian Dersha, the COO of the Synergy Dental Partners. We're a group purchasing organization. And our presentation tonight is so exciting. We're featuring Mary Hughes, who's the CEO of Dental Education Partners, also a well-known speaker. Some of those in the audience may have seen Mary before, and a seasoned hygienist for many years. Stephanie Palmer, who's the Chief Operating Officer of the Dental Education Partners. So she works with Mary, and she's got well over a decade of experience in the dental industry. And so excited to see Dr. Monil Mehta, a well-accomplished dentist who practices in Minneapolis, Minnesota, where I understand the weather has cooled quite a bit. We're in the fall season now. It's great to have Dr. Mehta with us. Before we get going, I want to thank our sponsors, Care Credit, which I'm guessing everybody in the audience has heard of Care Credit. Most in the audience are probably customers of Care Credit. And then again, the Synergy Dental Partners, which is the largest group purchasing organization in the dental space. We have thousands of dentists that are members, and we leverage the purchasing power of all those dentists to negotiate really great deals with suppliers for all of our members. So today, Mary, Stephanie, and Dr. Mehta will all talk about navigating the tightrope of increased wages, which we're all dealing with, hygiene production, and supply costs. And again, I think that Tori mentioned it, but if you have a question during the presentation, just throw the question in the chat, and we may go through some questions as we go along. And then at the end of the presentation, we're going to open it up for a variety of questions and answers. We may run slightly past the 8 o'clock hour, 8 o'clock on the East Coast. So it may run a little bit past an hour, but I'm sure you'll agree that the content is extraordinary and it's well worth tuning in for the entire session. And with that, let's bring in our speakers.
Awesome. Wow, thanks for the introduction, Brian. We're really looking forward to it tonight.
Yes, it should be great. I think, even when we start to talk about a lot of these things that are happening in dentistry in general, I think it's always helpful to start and begin anything with why. And why are we focusing on hygiene? And also, we're going to talk tonight quite in depth as far as some of the realities that dentists are facing today in hygiene. And while, many of our patients like to think of us just as sort of the cleaning person, but the cleaning person, or the person who cleans their teeth, we make them feel great. We know lots of things about their families, their lives, and all of those types of things. Owner dentists actually know that hygiene plays a very fundamental role in any general dental practice because it impacts patient retention, it improves case acceptance, and 75% of the dentist schedule for the next 2 weeks actually comes from the hygiene exams from this week. And as all the dentists that are on here know, gingival health actually improves restorative dentistry. It improves the longevity of the restorative dentistry as well. And oral health, as we all know, improves our patients' overall health significantly. However, recently in dentistry, we faced quite a number of challenges, especially when it comes to the hygiene schedule. And Stephanie, what are some of the top issues that you've heard from offices?
Well, there you just showed them. It's not hard, and I think so many of the attendees here are probably feeling this a little bit. But thank you, Mary. Thank you for asking. I'm so glad that you did ask. Actually, earlier in 2023, the ADA had a poll, and these were really the top two challenges facing practices in dentistry: staffing, of course, inflation, right? We're witnessing that everywhere in the economy, but certainly in dentistry as well. And in fact, relative to staffing, over 90% of dentists, this is astonishing, reported finding hygienists was extremely difficult, challenging, and no doubt we experienced this during COVID, but even past pandemic, it's really a couple reasons. Is the retirement rate really aren't keeping up to pace. It's actually, let me rephrase that. We aren't bringing on the new hires, right, to keep up with the hygienists that want to retire. We have all witnessed the wages going up and up and up, and our hygienists asking for a little bit more, getting those new recruits. I mean, we're seeing some astonishing hourly wages out there out in Oregon. They're asking for $60 an hour. I don't know, Dr. Monil, I don't know what they're asking up where you work, and curious what some of the attendees are experiencing out that are attending tonight, but it's been astonishing. So I think really, I'm going to turn it back to you, Mary, because I would like to hear from you is what has been the impact on all of this?
Well, finding hygienists, obviously we've all known of this year has really been a struggle, but it's also created a significant impact also regarding the access to care for our patients, right? So if a practice is forced to reduce capacity, let's say, it could potentially hurt the office's ability to accommodate their active patient base with the same recare frequency as before. And during this time, a lot of offices have had to incorporate different strategies, like staggering hygiene schedule and bringing in a dedicated hygiene assistant just to maintain the current patient's recare intervals on that. And even before all of this, even before this issue that we've been having with rising cost of hygiene wages and trying to manage the business from the business perspective of the dental office, even before that, it also has been a challenge too for us to really treat our patients comprehensively in the hygiene chair itself too. So even before all of these challenges, certainly we knew that over 80% of the offices in general practice were not providing the standard of care to treat periodontal disease as it was before, and even more so, I think, today. The AAP actually referred to periodontal disease as an epidemic in 2017, 2018, when they first introduced the guidelines for hygienists to follow in the general practice. And they showed us in these guidelines that according to the AAP studies, as well as the CDC, we know that 47.2% of our adult patients over the age of 30 have some form of periodontal disease, even if it's early perio or stage 1 perio. It's quite a few of our patients that we see every single day. And then as our patients get older, and from 65 and older, our baby boom patient base that we have in our office, this number jumps from 47% all the way up to 70% of those patients that are challenged with having periodontal disease. When you combine these two groups of adults over 30 and then our adults who are 65 and older, this translates to about 75% of our patients that present with periodontal disease in the general office each day. That's on just a regular hygiene schedule. And so because of this too, we also know, because of research, the oral systemic relationship that oral inflammation has with the rest of the body. We know that there's a direct connection between inflammation of the mouth or bleeding gums the inflammation of the mouth, and chronic diseases. And some of those diseases are very well known, and some of those are new. Certainly the more well-known ones are cardiovascular disease, diabetes, respiratory infection, Alzheimer's, different types of cancers like kidney cancers and pancreatic cancer is all linked to inflammatory condition of the body. And generally, a lot of times that can be found in the mouth, right? But by being truly comprehensive and treating our patients that do present with periodontal disease with periodontal codes and billing, which is really the ideal in the general practice, we can actually lower the patient's risk for many of these diseases. And in some cases, we can even decrease the worsening of systemic illnesses that they may already present with, that they may have already had, the worsening of those conditions. So when you connect the patient's health history with the way they present today for their hygiene visit, we know that the patients, many of our patients, should be walked out with a perio code instead of a prophy code. However, in most cases, that's not what's happening. Most of our patients in the general practice are walked out with a prophy code, but perio services is what's being done on a lot of our patients. In fact, when you look at the studies across the United States, most offices in the United States of the average general dental practice has about a 15% perio diagnosis rate. And, really, when you look at that, that doesn't even come close to what the statistics are, as that I just shared with you from the AAP and the CDC as well. The average general dental practice reports that they have more prophy codes walked out than they do perio codes, with about an 18% prophy to perio ratio. Many offices don't have dedicated time that's blocked in the hygiene schedule to accommodate scaling and root planing patients. If they're diagnosed today, there's no access to care. And many offices that we work with actually share with us that their first opening is in March or April of 2024. And it's difficult to create a sense of urgency with our patients if they present with oral disease to say, hey, you need to get this treated. This is really important to your overall health, and we can't get you in until April of 2024. And so I think that really does impact the general practice, right, without having those availabilities too.
Right. So, hey, Mary, if I may interrupt you, before you move on, I'm just curious, the attendees that we have on here today, again, feel free to ask some questions, comment through asking the questions, and our moderators are going to see this. We're all going to see it. So we'd love to share it with the other attendees. But it's interesting you're talking about no SRP blocks in the hygiene schedule. And the reality is some of you may have them. We were just doing a training in an office the other day in Texas, and they actually, the hygienist was showing us they do have SRP blocks. But then when we looked at them, it was being filled with maybe perio maintenance or so perio, but it wasn't a block for an SRP, when that patient really so urgently needs to treat the disease as soon as possible. So I think that, I think that this is really, really a key thing. The other thing that we found is there were several newer associates who were new to the practice, and when we were talking about perio in general, some of these codes and things you were mentioning, the codes, Mary, they weren't necessarily familiar with the D4346, which is one of the newer codes. Or even some of the other codes, they weren't familiar with the full treatment presentation or plan for treating perio in their office. And I think they just, in many cases, thought the hygienist took care of that, right, being the specialist of gum disease.
Yeah,
I'll interject there.
Yeah, the doctor.
Yeah, I took over for a practice. I bought out a practice last year, and he was a fantastic clinician, but there was so much undiagnosed perio, just from patients that had gone through and probably progressed over time and hadn't been told that their condition was worsening, or they were aware there was recession, but to them it was just normal. There's a lot of that in offices, and how you broach that topic to a new patient is very important. You can easily scare off a patient if you come off too strong. So one of the things that I found worked really well for us is to probe, show them the data, show them what healthy looks like, and then say, look, your numbers aren't your probing depths, your condition, your symptoms isn't normal. But I understand that this is probably news to you right now. I'm going to give you a chance to kind of improve on these numbers if they think that they can just brush their way out of it. And in 6 months, if things haven't improved, we'll have to intervene. But otherwise, that's an easy way to kind of not be the bad guy for a lot of years of undiagnosed perio. I mean, as far as hygiene openings, we schedule personal new patient openings and hygiene openings and SRP visit in our schedule. And we've actually had new patients call us when they've been diagnosed by perio by another office and haven't been able to schedule that perio visit for months, but they want to get moving on it. And that's an easy patient conversion for us because all the work's already been done by someone else. We just have the opening in the schedule for it.
Yeah, which is ideal, and plan for it too. It sounds like too, when you're planning for, we're going to need this time. Now, obviously, you know, if it's not filled 24 hours beforehand, certainly we have a lot of patients on short call lists that we can call and contact too. But I think it's also planning for that. You're absolutely right. I think that's happening everywhere. And that's important for patients to know and offices to know that you would, of course, be able to see the patient and accommodate the patient, and the patient needs the care. So even though it sounds like, you know, oh, we're booked out, and that's a good thing, which in many instances it might not be. And what's interesting is we do know what to do when we see the patient in the chair, but that's not necessarily always what happens, even when the patient is in the chair and we know that they maybe do require periodontal services and they're on the schedule for a prophy, and we do know that they require the perio services. We do know what that looks like, but you know, bridging between what we should be doing or what we currently do, right, is really the key of trying to be able to, you know, look at hygiene in a different way. And most offices, I think, without making an intentional effort on the schedules, like you just mentioned, Dr. Mehta, is also too is that they just evolved this way. Most hygiene schedules just, they have an hour blocked, but if it's a new patient, they have 90 minutes, and if it's an SRP patient, we put them in for 90 minutes also too. But we do know that the way they present today might not be a healthy cleaning. And so we kind of look at how do we treat this patient? And the reality is a lot of us are shaped by our patients as well. Sometimes the patient, you know, the demands will be such as they will even tell us, I only want my free cleaning, or maybe we don't have systems and processes set up in the office to where we can then put in a treatment plan, have the doctor come in and do a confirmation of diagnosis and confirm the diagnosis, and then move them into treatment that day. So we just don't have the processes necessarily or the systems in place. And so while as hygienists, we know what the correct procedure that's needed for the patient is to get the best patient outcome, it sometimes is easier just to do what we've always done. And the practice that you're talking about for your practice currently he was a great doctor. And a lot of times we would just go in and scale those deeper areas during their healthy cleaning. And there was no documentation of it anywhere that we did it. There was really no billable codes on the ledger that we could see where it walked out on it. And it's interesting, Stephanie, you had brought up too of the associate dentist, you know, not being familiar with a lot of the codes, which is true. But I also think it comes down to us as hygienists. I think most of the doctors that I work with, they actually are expecting that the hygienist is going to lead this department, because we are the ones that are supposed to manage that side of the house, so to speak. And so they're anticipating that we're going to lead this side of the practice. And I think as hygienists, we feel like we don't have the authority to do so, partially because we've never come to you, doctor, and said, hey, I'd like to be able to manage the schedule this way, or actually lead that side of the practice too. And I think, you know, for years we've studied the effects. We know all of the effects of inflammation. But I don't know if we're waiting for someone to take a toothbrush and kind of knight us on each shoulder with a toothbrush and say, you hereby, hygienists, have the authority to manage that side of the practice. And I think we rely a lot of it. We just defer it to the dentist of, well, you should diagnose. But I think it's also true that we're looking at the patient through two different lenses. Me from a foundational perspective, doctor, and you from a restorative and functional state of the patient. Together, we're supposed to create this comprehensive blend. And I think if we just kind of punt it to the doctor and say, well, you're the one that has to diagnose because I'm not authorized to diagnose in my state, which is true. We are authorized to help the process by making a hygiene diagnosis and then transferring that to the doctor when you come in, certainly for the exam, right? And so being able to tell you those types of things and talk to the patient and speak to that as well too. It's difficult, I think, in many ways to try to achieve that excellence in hygiene when we're struggling with who's supposed to do what and which point of time in the patient's appointment are we supposed to do it. And I think understanding that as hygienists, our role is critical in the dental practice because we can offer patients with, you know, a high level of service and being able to give excellent patient outcomes for it as well too. And, you know, really looking at how most offices operate, they generally don't have a documented process in place. And if they do, most times it was with a different team because we've had transitions in staff team members over the last 12 months. And so we haven't really updated a lot of those processes. You know, even now, most businesses, when you're meeting with different types of companies, they're focused on 2024 already. They're already in the new year saying, what's our business goal? What's our financial plan for the new year? And with dental offices, the dentist is so busy working on patients, working in the business, it's difficult sometimes to actually be able to pick your head up and focus on the business aspect of it. And I also think too, it's difficult to track a lot of different types of metrics of how the practice should be doing. And I know we were talking.
Which ones, Mary, sorry to interrupt again, but which ones even to track?
That's exactly
so
right.
many.
If you don't track any, if you don't track enough, then that's not helpful. If you track too many, that's not helpful because now you're sort of, you know, paralysis by analysis, I think in some ways too, of looking at what those KPIs are or what those business performance indicators or patient care results we should be looking at, right? And understanding that there's many different ones to look at. And I think it really comes down to really being aligned as a team and document whatever that system or protocol is for your office, right? And like I said, most offices have aligned at some point in time, but that hasn't been updated because the hygienist that actually updated the hygiene process left 2 years ago and retired. And we've had new hygienists come in. They didn't know they were supposed to do it. They didn't even know it existed, right? Or being able to bring in the AAP guidelines if the office currently isn't using that, sitting down for a team meeting to say, hey, are we all diagnosing the same way? Or is Mary the mean hygienist that's talking about periodontal disease? I want to see the other nice hygienist who doesn't talk about it. And that sort of thing. So making sure that we're aligned even in how we diagnose. And if there's associates, oftentimes I'll just hand the patient off to the associate the same way that I did the owner doctor. And maybe that's not what they wanted. Maybe they wanted something different, but we never sat down and took 5 minutes to really talk about it, right? And really systemize the way that we hand off. And hey, doctor, do you want me to introduce you to the patient? Do you want to introduce yourself? Do you want me to talk about suspect teeth? Do you want me to give you what medications the patient's on? If they're on medications that cause dry mouth, will that change your exam? And if you put something on watch, or if you go ahead and restore because they do have dry mouth conditions and all of those things. And these all seem really easy in principle. I think they all seem like, yes, of course we should do this. But I think so often we get so busy during the day, it's difficult to actually go back and revisit these. And I know, Dr. Mehta, you actually place a really high emphasis on this type of system and process in your office as well, too. And maybe you would share really for you what's working for your office.
Yeah, so obviously everyone can have their own protocol. Everyone can optimize and train for handoffs. What I've found is that you can have a system in place and it'll function and people will obey it, and then you'll get into a groove and won't talk about it, and then people will get into some bad habits, or you yourself will get into some bad habits, and that system will slowly deteriorate. So we've set a quarterly meeting for the entire team every quarter, and we talk about anything and everything and rehash all of our protocols, just make sure like this is how we want to do it. This is how it should be, and just one up on it every time, every quarter. I also like pointing out when a certain workflow, like say something works out really well on one particular day at the end of the day, I'll make a point to tell everyone like, hey, I think that worked out really well and we should do it that way more often. And the workflow from that, the handoff was really successful. I like your verbiage there.
Okay.
Things like that. And that'll emphasize good behavior. And likewise for things that I didn't like, point it out at the next morning meeting and tell them, hey, this didn't really work out how I intended for it to work out. Let's not do it that way anymore. And just having consistent follow through on that, I think has really helped maintain our protocol and continuously have me evaluating it to continue to keep optimizing as things change.
Yeah, absolutely. And I also think too, even like you made mention actually a couple of times of meetings, dedicated meetings that you have. And I know that we got away from those for a long time. And we really do have to get back. It's the one place where we can sit, and we always say, you know, where we're not talking in front of the children, right? Where we can talk outside of patient care and we can iron out some of these things as well. And I think that's the key too. And having that leadership from you as the doctor.
The team actually enjoys it. We only block out 2 hours for it, and they know that that's the time period where we'll get lunch catered in. So they're motivated by the lunch to pay attention, and it's only 2 hours, so anybody can really make it through it. And we kind of keep it brief. Me and my office manager create a PowerPoint and kind of just buzz through it.
Yeah, I love, and the agenda, I think that's key too. I think some offices shy away from it because they worry that it's going to turn into sort of a what's not working session or a complaining session. And actually, sometimes it can go down that road. And in our office, we will designate what we call the traffic controller. We have a stop sign and we alternate who has the stop sign. And when we start going down that road, they have to hold up the stop sign and we have to stop because we've gotten off topic.
Penalty flag.
Exactly. Because I think sometimes that can sort of hijack the meeting, for lack of a better word, it can. And then it's not really comfortable for anyone. And it's not really helpful, I don't think, as a team, really, I think in many ways.
You know, there's a question that came in that I think is pretty relevant to what we're talking about now. The doctor's saying we've hired a few part-time hygienists recently. So how do you train the part-time hygienist on the communication during the handoff?
I think that's part of the onboarding. Anytime we hire someone new, they don't start seeing patients for at least a week. They have a full week of onboarding onto our systems, our software, making sure they know how our workflow is. I know private practice, DSOs are really good about this. They have a full formal onboarding program. Whenever I hired both my hygienists, they were amazed that there was even any onboarding. In previous private practices that they were hired onto, they were seeing patients their first day. But how are you going to be on the same page if you just throw them into the fire?
It's not uncommon. I think what actually some dentists will do is they will have working interviews in advance. Right. So there's a little bit of that. Make sure they can jump right in. So if you're doing things like that, then maybe, but I couldn't agree with you more, Dr. Mehta. You really need that extra time with the person to set them up for success.
Yep. If we can go back to the previous slide. Yeah, so some of the things that have really worked for us is having the hygienist know. I've sat down with them and told them, this is what I'm looking for in an exam. This is how my exam works. And we've formulated our exam tabs in our practice management software to flow exactly in the order that I would go. And they know what I'm looking for. So when they're doing the prophy or they're doing a new patient exam, they know what records I want ahead of time. They know that we'll bill for any billable records. If they're not due for record, I still want the record. So go ahead and get the record. We just won't charge for it. But it all helps my workflow. So it's all queued up and ready for me. And especially when they know what I'm looking for, they'll talk to the patient and tell the patient straight up that I think he's going to be concerned about this. He'll probably talk to you about this, but let's see what he says. And then it's not a surprise when I come in and A, either meet the patient for the first time, or B, am still a younger provider, so I'm taking over for an established person. come in and tell them they need this, this, and this done. It's not a surprise. I'm not the first person to tell them. I'm not the evil dentist telling them they need 3 crowns. It's teed up for me. So I think case acceptance goes up a lot when you and your hygienist are on the same page. Also, the hygienists need to know to frame things, and we as dentists need to know how to frame things as coming from a point of concern and not straight up telling the patient, you need this, you need this. You need to come from a point of concern, show them the problem, and have them ask you for a solution. Don't give them a solution before they ask for a solution. It's so much better for the patient in terms of their psyche when going into a treatment. I'm sure we've all had patients where we've done a crown prep and they come back and need endo, and they said, well, my tooth didn't hurt until you touched it. That could all be avoided if the patient was the one that asked you, hey, how do I fix this problem? And you tell them the crown. And even if it does end up needing an endo, they were the one who asked you to do the crown. You didn't tell them they needed a crown. I think those little things and subtle cues, having you and the hygiene team on the same page, really help in terms of treatment acceptance, making the workflow a little easier, and having ample records and ample time for the hygienist to be able to be comfortable diagnosing perio, or you empowering them to co-diagnose with you.
Yeah, I think that's really important. And I think even a couple of people have commented here too. You know, it's interesting. Most of the onboarding in most practices, and a lot of the attendees have shared this in the chat as well too. Most of the onboarding is, you can put your purse down over here, Mary, and that's where sterilization is. The break room's in the back and your first patient's here. And that's the extent of our onboarding. We don't actually, for whatever reason, maybe it's because they are really in need of a hygienist or they're short staffed as it is, and we just have to jump right in. But then if that is the case, I think creating specific time, as you said, to say, here's how I would like the patient handed off. Here's the type of phraseology I'd like to use in front of the patient. Because you're absolutely right. I work with a doctor who requires an intraoral picture of every 3 or more surface filling when they come in to do the exam. And the doctor, the way I found out that that's what the doctor wanted is I didn't do it. And so when I had waited for 22 minutes for the exam and the doctor came in, they said, how come there's no intraoral picture? And that was sort of my onboarding. I guess sometimes it's by trial by error, and I think making mistakes. And I think that can create a lot of frustration. So I love hearing that you actually, during the onboarding process, set aside time to do that. I think that is very important. It really sort of calms the chaos, to say the very least, in dentistry.
For the next slide, I want to talk a little bit about creating a culture where your staff is receptive to what kind of practice you want to build. Having everyone on board and bought into the vision of your practice and creating an office culture that is magnetic, I think has been really good to my practice's success, and I think could help a lot of practices. You want to really get to know your staff. You want to get to know what their likes and dislikes are, how they operate. Be open to changing your workflows if they make a suggestion that might improve the workflow, because they're the ones doing the hygiene. They're the ones doing the assisting. They're the ones who know what works day in and day out, because we only see our perspective. If they make a good point, it'd be open to change. And I think if you are open to change and not my way or the highway, people will respect it. People know that you're listening and actually value their input. When you're hiring, make sure no one is being selfish. You got to show them that there's no job that's too big for anyone. I would a hygienist who we've all heard stories of hygienists who look down on assistants, or assistants vice versa, or territorial claims of this is my realm, this you don't touch this. My team's seen me take out the trash. My team knows I won't ever ask them to do something I won't ever do. They see me work in hygiene patients when someone calls in sick, and I work in my second column. I'll do hygiene exams. I'll do prophy. I'll do SRP. I'm willing to do anything for example, today I had a new patient. I usually bring in new patients in my column. And if it's just a simple prophy, I will do the prophy just so I can build more of a rapport with the patient. But my hygienist knows I hate doing it. And she had a cancellation at the same time. So she let me do the exam and then volunteered to do the prophy when she didn't have to. Or when one of the hygienists, both of mine hygienists are pregnant right now, so they're soon to be on maternity leave. They know to when one calls in sick or on the off chance somebody else is sick, that we might need to pick up slack. And they, at this point, they volunteer to do assisted hygiene when needed. So I'm very happy with the team we've cultivated. If you build the right culture, I think people will want to help you out. Like, they know if you're working hard and you're the first one in, last one out, that they know you're working hard. So you're not just some doc who's slacking off, and they want to help you. Everyone in my practice knows that if work needs to be done, I don't care who does it, it just has to get done. I like to let my hygienists work to the top of their license. They got laser certified as soon as I bought the practice. They get sent to CE. They're excited about learning. I nerd out on new procedures and things, and I want my team to be the same. I don't want them to be complacent. So if you empower them to work to the top of their license, treat new procedures, there's new things coming out for hygiene like Curodont or new procedures. A lot of practices don't talk about that with their hygienist. They just implement it on the doctor side. But even from your workflow standpoint, if you let the hygienist do it, that's production that we as a practice owner could be benefiting from without us actually doing the treatment. And it's better for our patients too. I think that empowering your team to work to the top of their license only generates more money for us.
Yeah, absolutely. And better patient outcomes, right? I think that's the ideal. Like you said, with a laser, I mean, so many of us have seen such great patient outcomes when we have implemented technology and we have implemented things that, you know, we were able to do at the full scope of our license, to your point.
The last thing I'll touch on this slide is you want to create fun incentives for the team. When you identify what's working and things are working well, create new incentives for things you want to positively reinforce. I've liked where our new patient flow is going, and I think Google reviews have been a good part of that. So this last month, I hit my yearly goal for the Google reviews, and I said for every 5 after this, I'll buy lunch. So every 5 above our goal, I'll buy lunch through the end of the year. I've never seen my team work harder to get a better patient experience, to earn a review. In the last month, we put up more Google reviews than we have in the last 5.
So nobody's had to bring their lunch. That's awesome. I'm like,
Yeah.
no, docs got it.
But at the same time, our online ranking as a practice has shot up SEO wise. So in the end, I'm getting it back either way. But
Nice.
the level of excitement and engagement from the team has really shot up as a result of a fun incentive like that.
Yeah, that absolutely is. I think that's really awesome too. It's interesting that one of the things that you said is I'm willing to do things myself too. Phil Knight, who was the co-founder of Nike, right, is being really sort of noted as saying, when people would say, well, what is your job exactly? Or, you know, what do you do? And he said, my job is not done until the job is done. And I think that that's key, is making sure that leadership is demonstrated too. I think that's key for a lot of practices as well too. And I think, to your point, we do have to define our culture and in our office and what makes our office unique, right? Yes, of course, provide competitive compensation packages and benefits and all those things, but some of the things you were talking about, like those fun incentives, we actually did a high five. You would get a high five if your name was mentioned in a Google review, and the doctor would have a $5 bill, and we'd give you a high five and you got a $5 bill. It doesn't sound like a lot, but it was really a lot of fun, and we were all trying to get the high five at the morning huddle, I think. And being open to flexibility. You mentioned your hygienist, both of them being pregnant. I think has to be some flexibility within the schedule as well too. And And like you said, really empowering hygienists and your team to work within their scope of their license and be able to encourage them to go to CE. Like you said, I want them to learn these things. I want them to learn this new technology or these types of materials that are now being used with great results and great patient outcomes too. So I think, when we're talking about offices, Stephanie, I know you spent a lot of times supporting teams with recruiting, and also with helping with onboarding and things like that. What else have you found as far as some helpful ways?
Yeah, absolutely. I think, that touching back on the onboarding, really understanding the roles and responsibilities of that specific office, because if they're coming from a different office, it might have been different, right? Certainly, you talked a lot about the handoff and things like that. So be sure understand that communication, both as a team, love that quarterly meetings. That's so fantastic. But also one-on-one. I have to say, when dentists will give a hygienist some of their one-on-one time, it's literally it's so well received, because it's so rare that they get that, right? Everyone's so busy at the end of the day and they got to go home to their families. It's been a long day. They've so just spending some time one-on-one, I think, is helpful too. Also, you talked about food, right? You have to find what motivates your team, and food can absolutely be one of those things in a dental office, but recognition that actually aligns with the employee's value. This is a new thing all over in corporate world today, is finding out what motivates your employee and what kind of recognition they are looking for. And if you can dig in a little bit on the personal level, individual level, and really see what that is, I think that can go a long way. So yeah, I think we've touched on that. Certainly, if there's questions, please ask away. But I think let's jump to the production side of things. And I know, Mary, you got a lot to say on that.
Well, I think a lot of it too has to do with, not just having prophy after prophy after prophy and those types of things, but being aligned and being able to provide those types of procedures that actually help the patient. Ultimately, we can bill out for those as well too, so they help the practice. And there are specific core drivers of any successful dental practice, right? The core drivers are the patient visits, the diagnosis, and that's, between myself and the doctor as well too, case acceptance and being able to provide patients with third-party financing so that it's comfortable for their budget, especially this time of year is making sure that it's comfortable for them to get the treatment done as well too. I think, aligning on that diagnosis of being able to phase out dentistry if the patient needs restorative and they also need scaling and root planing, being able to coordinate that with the doctor to say, let's go ahead and get started on the upper right since they need a filling or a crown or whatever. I'll do the scaling and root planing, and then they can go ahead and have the restorative with the doctor as well too. That helps to show the value that we value the patient's time, certainly as well too. And the keys to success that we've really found is really understanding what the industry benchmarks are in hygiene, as far as what is the patient visits today, what is that average visit per day for hygienists, understanding where we are now in the practice and where we want to go, and then setting a strategy of how we're going to get there, and setting goals that are professional development goals, not necessarily about money, but even for preventative goals. Maybe for our office, we could maybe do a better job preventatively with our patients. How do we get there? Maybe it's asking the doctor to incorporate a fluoride varnish when they seed a crown, so that the patient is set up that when they come in for the hygiene visit, if I say, I noticed that when doctor did the crown, he also recommended a fluoride varnish. You got one the day that you had the crown inserted, so I am going to do it today after I polish your teeth. And making sure that we're scheduling to achieve the clinical care goals of the practice, as well as the financial needs of the practice as well too, and then measuring those, right? And so really measuring those goals. It's interesting, Dr. You had said, we've all done that. We've all set up things and benchmarks and goals for the practice. And then daily life kicks in and we're like, oh yeah, we set those up like back in February. We should look at those again and see how we've been doing. But also too, I think, it's accountability. And I took a course recently and the speaker talked about responsibility is given, but accountability is taken. And I think is holding ourselves accountable for what we want to become in our careers. And I think it's easy to stagnate as well too. But I also want my doctor to notice and probably give me recognition and things like that. If I have done a lot for the practice and the patient outcomes, to maybe be able to make reference to that too. And when we see what's actually possible in hygiene itself, we know that hygiene doesn't have to be, oh, well, we have to hire a hygienist because we need one. And this is going to be an area that I really have to focus on because the hygienist won't. It can actually create a profit center within the practice as well. A lot of the services that we do are reimbursed by insurance companies. I was talking with a doctor just yesterday and I said, how much does typically insurance cover for a crown, or what is the reimbursement for a crown? Doctor said usually about 50%. I said, really? Because I get 60 to 80% on my services, right? And that's for the whole mouth. You're just doing that one tooth. But I think part of that too is understanding that the hygiene production that we do bring in is a very essential part of the overall practice. In fact, other than you, doctor, we're the only ones that have a provider ID. And so we are accountable to helping the business as a whole. Yes, of course, helping the patients, but also helping the business too. And understanding that we're supposed to bring in hygiene 35% of total office revenue for on any given month, right? So I think it's important to kind of look at that as well too. And looking at how much is produced throughout the day. If we're walking in, I think it's great that hygienists have gotten the wages up as high as they have, but then we also have to make sure that we understand what our role is in the practice and the success of the business as far as case acceptance and things like that too. I think that's from a clinical side, but certainly I know that there's operational sides of things that also help the practice. And I know we have, practice leaders on the meeting tonight, on the call tonight as well too. So I know, Stephanie, you focus more on the operational side of it as well. So what are some of the things that you've seen that have really helped offices?
Yes, I think let me tee that up a little bit and say that when we work with teams and we see the hygienists really doing a very good job on perio, well exceeding some of those metrics we saw earlier. Their diagnosis is great. They're treating SRP, they're doing preventatives. It looks amazing, and yet we're not seeing it come through on collections. Then we have to say, aha, what's happening? And really what we see operationally is it might be that the fee schedules aren't accurate or up to date. Maybe actually even the person working in front desk doesn't understand the difference between out of network or in network. Maybe because they didn't have proper onboarding or things like that. Insurance verification, so important. So important. Actually, one of the ones we've been talking a lot about lately is insurance verification on your perio maintenance. Right, Mary?
Yes, and actually being able to look, and I know that there again, though, too, that's another task, right? So there's companies I know that are out there that actually help with, doing insurance verification and credentialing and things like that as well, too.
Yeah,
and
absolutely. If you don't have the expertise, we definitely recommend that you go with a company that's reputable, that's well referred and knows what they're doing. Schedule management, of course, we can't do this without it. And then, of course, setting up the explosion codes for making sure that when we are going in to treat a perio patient, that whoever's scheduling that for them, they can just, do maybe it's like SRP1 or something, SRP2 for stage 2 perio. Things that you can do, making sure you have the right narrative, right? Box 35. So that we're ensuring that we're maximizing the insurance reimbursement. So those are definitely some of the things we want to keep in mind. Truly, hygiene is a team effort.
yeah, absolutely.
Schedule management. Question coming in. Right now, we're booked out until March of 24 in hygiene. When do I know it's time to hire another hygienist?
Oh, I can take
There's
that.
also a bunch of questions about hygiene temps as well.
Yeah. So I could take that one. If you're booked out in hygiene until March of 2024, that's booked out too far. You need to have either some openings already baked into that schedule, or you need to start cutting some insurance plans. Because if you have adequate number of hygienists and your schedule is already full, adding one more hygienist is just going to it's going to increase the volume your practice does, but it's not necessarily going to increase the productivity because you're going to spread yourself out a little bit thinner as a doctor, and you'll have less time for treatment, and then that hygienist schedule is going to fill up. You're essentially just going to become a hygiene mill with no time to do treatment. Now, if you're a short hygienist and you're just booked out to March because there's just not a bit, that's how far your one hygienist or two hygienists are booked out, that's a different story. But if you have a good number, you don't want to be the only practice that's booked out that far because you're the only one with hygienists and no one else is, everyone else is dropping plans. So you're just getting people coming to your practice because you're the only one in their network. Those patients are low value patients to a practice, and the lifeblood of practices are new patient flow. So if you're fully booked out until March, you're not really getting new patients. You're just getting a bunch of your own existing patients over and over again who are just coming back. The value of a returning patient isn't as high as the value of a new patient. So you need to value how far you're booked out for new patients, not existing patients.
I would also wonder if maybe take a look at your no-show and cancellation rate. I know that's a huge thing right now. And it might be that if you're typically scheduling 8 patients a day in hygiene, and so you're packed, but then when you look backwards and your average visits per day is maybe like 5 or 6. So that's something to keep in mind as far as how we schedule to account for proactively these cancellations and no-shows.
Yeah, that's actually something that we did, Stephanie. That's interesting that you brought that up, because we actually were experiencing a lot of even patients that confirmed, and even an hour before, oh yes, I'll be there, and I'm leaving now and whatever, and they still didn't show up. We experienced that as well too. We did change the way that in our confirmation process, where we would say, if we don't hear back to you by the end of today, we will still try to see you should you come in. But of course, because of patient demand, we will have to put you on a schedule. Should you come in, please call our office, right? To confirm that you're coming to this appointment. If they don't, we actually looked at our cancellation and no-show rate. It was right around 25%. So we would maybe put a staggered patient on a half an hour in a schedule that was an empty column that didn't really belong to anyone. We do have an assistant that actually floats between restorative side and hygiene side as well. And whoever's available will see that patient. But if my patient doesn't show, I now have a patient, and we are able to address the high cancellation and no-show rate as well too, by being able to work out of 2 rooms, but they're not side by side booked. They're actually stagger booked with an assistant. So interesting that you did bring that up. I know that personnel is a question that comes up a lot, but a lot of offices have moved in that direction. And Dr. Mehta, I think you had even said too, now my hygienist, if one of them has to be out, the other one will say, that's okay. Can I use one of the assistants? And we can, still see the majority of the patients in the other hygienist column, but being able to work like you do between a couple of rooms.
Mm-hmm.
So absolutely. I think that's one way as far as personnel, but I know there's also other ways that we can create profitability within the practice as well. Brian, do you want to speak to this?
Yeah, I'll talk for a second on this. And it seems like the narrative changes month to month almost on this. I mean, there was inflation, and now is there disinflation? Inflation's coming down, but if inflation's coming down, why are my prices not coming down on anything? So, what is going on? Well, what's going on is that on most of the stuff that the dental office has to purchase every day, prices have gone up, and they're sticky, and they haven't come down, and they may be even nudging up more. It's almost like, somebody raises their price and then everybody else has to raise their price. So what have we seen? We've seen, coming out of the pandemic, PPE is sticky and expensive and not coming down. Supplies for 95% of dentists, I'm surprised it's not 100% of dentists, are reporting that supplies are more expensive. And then, an average practice is going to spend, I don't know, 10, 11% of their revenue on labs, and lab fees are going up. And so how do you as a practitioner manage all this along with hygiene shortages and wages going up? It's the sweet spot of what we do at Synergy Dental Partners, which is negotiate on behalf of dentists. So take that off of your plate as a practitioner. Don't worry about having to negotiate or having anybody on your team worrying about negotiating, whether it's about a hygienist or an assistant or whoever does your ordering. Let somebody else do that work for you, like a DSO would do. And, look at particularly GPOs that can leverage buying amongst thousands of practices to bring costs down for all the things that you need to run your practice on a day-to-day basis. So yeah, that's something we all have to be watching for as well.
Yeah, absolutely. I think also offices that set budgets for a monthly budget for supplies and labs, and we know what those are ahead of time. To your point, being able to join with a GPO that understands these costs are going up and they need to be negotiated, and also training your team on how the ordering process, right? Not sometimes some offices, the doctor will say, well, they actually order every single day. And, maybe setting up a process around that or a system around that of, here's the supply expenses and the lab expenses, and then here's the frequency. And also, I know, Stephanie, you work with offices on looking at profitability with dentists as well, too. And what are you looking at with them?
Well, this could be a whole course in and of itself, Mary. I want to say
you could do it also on the personnel shortage as well.
Right. Absolutely. But no, thanks for bringing this up. And I you can see here kind of, it's like where we were before. I think the industry benchmark, we were trying to achieve that, expenses were 75% of income, but now where are we with some of these rising costs? I know that certainly staffing's up, supplies up, labs up, perhaps even others. So now it's more challenging than ever. How do we drive that profitability? And then we have some questions about how do we recruit, and hygiene wages are going up. So how do we make this all happen? And so I think you really do need a strategy and work with somebody who can help. Brian mentioned work with a GPO, and definitely I think it's be mindful though. If you haven't actually set a budget before, you need to do that going into 2024, so how much you can afford when you're going out to hire someone, or if you're bringing in temp because that's all you can afford. We need to know what that is. And there are some new creative agencies out there that are willing for you to set your own budget on that. So definitely, I think, like I said, if many owner dentists have a pretty good handle on this stuff. If you're not really sure how to get started, I would say find somebody who has experience in this area.
Yeah, for sure. For sure. I think that is a lot of it. And also making sure that we analyze that and monitor it, and also to making sure that we're looking at the changes that we're seeing and then being able to embrace those changes as well too. What we're saying, Doctor, you had said, stay up to date with any type of industry trends or new technology, and being able to talk to your team and brainstorm with your team too, and invest in training programs. And I think being able to, like you said, lead your practice. As a doctor, being able to lead your practice.
Yeah, I think embracing change every year is going to bring some new change, whether technology or something as far as economic market forces, labor shortages, or staff changes. Being able to roll with the changes and how you adapt to those changes will impact how you stay profitable. Essentially, you gotta be willing to change. I think the days of a dentist going out hanging their shingle and expecting success are over. And in this day and age, you have to be willing to adapt and go with the flow.
Yeah, absolutely. And also creating that stability for the practice as well too. I think, really take advantage of processes and systems. Certainly, it sounds like you've done that as well too. Maybe making sure that as a leader, doctor, share with me what your expectations are, and being able to sort of empower me, as you said you've done with your team as well too, using metrics and KPIs to revisit that and measure how are we doing to goal. And I think that's really the key to really looking at hygiene as not just a stone in your shoe, so to speak, but actually how do we create this as a building block for the practice. I think it sounds like you've done a great job with that. I worry you have 2 hygienists that are going to go out on maternity leave. You've had a couple here in the chat though that I think are maybe we're talking about taking a road trip to your office, but because that's going to be just for you too.
We've had some temps that have come up and stepped up for it, so but we are welcoming applications. So
yeah, it looked like there was a number of hygienists that they liked you, and then when you started buying lunch for the practice, they were all jumping in a car and they were road tripping up to work for you.
We were too. I was like, well, wait, I already talked to him first before this. And I was like, and I can't believe you didn't tell him, listen, you can't both get pregnant at the same time. That should have been in the interview. Right. But then that's what happens. We share the water or whatever in the office. And
they're off by 3 months each. So I think we got enough stagger there.
Yeah, absolutely.
And Mary, I think a couple of hygienists wanted to be knighted by your toothbrush as well.
Yes, exactly.
Right.
We do have the authority of that as well.
Right.
Yep. So we're kind of pushing the hour here. I'd like to get through there's a couple really good questions that I'd like to get through. And I know people want the code for the CE. A couple things here on the wrap. Let's do just a couple quick questions if we could. Mary, this is probably a good one for you. I think specifically the question is, what hygiene KPIs should our office be looking at? And I know you could probably talk about this for 45 minutes. And I'll just say before you answer, I've been guilty of looking at too many KPIs. I know we all have. If you're looking at a dozen or more KPIs, you can't focus on a dozen KPIs. Half a dozen at the most is probably all you really can be looking at and measuring and focused on. But what hygiene KPIs should our audience be looking at?
So actually, we typically try to keep it at 5, which is patient visits. It is prophy to perio percentage to see how many of the patients are walking out with prophy codes and how many patients are walking out with perio codes. Because we do want it to be reflective of what we know the statistics are. Certainly preventative therapies that we're doing with our patients. If we believe that we want to reduce future expense for our patients and being able to provide fluoride varnish or SDF or sealants or whatever it is that your office is currently offering for prevention as well too. So we look at those as well as case acceptance. And then for the doctor's side, the doctors usually will look at exams to appointment ratio for hygiene exams as well. So we usually look at patient care that are patient-centric metrics, which is, like I said, patient visits. That is something to be aware of, even though we're booked out. If we really go back and look at 2023, what has our average been on a daily basis? Is then being able to recognize that as being able to say, well, right now we're scheduled out, but we're only seeing 5.5 patients per day, and we're working 8-hour days. So in what ways, getting with the team to decide how can we maximize the access to care and some of the other percentages that really reflect our comprehensiveness with our patients and how comprehensive we're being.
Excellent. By the way, for the audience, the verification code, I think Tori just put in the chat, was max profit, which is, I think, what we're all striving for here is max profit. Another question that came in, and there was actually a couple. It's probably for the panel could answer this, but there's a lot of questions on hiring hygienists with staffing agencies and how to navigate around that and really best strategies. Does anybody on the panel want to comment on when you're bringing in hygienists from a staffing agency? And a specific question was, how do you achieve successful onboarding when you're bringing in hygienists from a temp staffing agency? Dr. Mehta, I think you hit on some of that earlier.
Yeah. Are we talking about like a multi-day commitment or a single-day commitment?
I'm not sure.
Well, I'll assume the worst case scenario we're talking about a single day commitment. If you just got somebody coming in, filling in a shift or two, we we have it set up to on the days that we have temps, my office manager or I will come to the office a little bit earlier than we normally do, go through the workflow, go through what we like, go through how to log in, how to use the software, where everything is in the one particular op that they might be operating primarily out of. And we schedule so that one of my 2 assistants is available to help as needed and is constantly aware of what the temp is doing at that time. So even though the patient, the provider is a temp or isn't used to our usual workflow or isn't used to our tech stack or how I operate, after 1 or 2 patients, they've usually got the flow of it. And most things that I don't really want the temp worrying about are already taken out of their control, like how sterile should operate or how the exam should go, because I'll have an assistant floating who is able to guide them and steer them into the direction I would already want.
I think she then commented that it was a single day commitment.
Yeah, so that would be the workflow for my single day commitment.
Yeah, I like that you actually will allot one of your assistants to sort of shadow and help. I think that's a great suggestion to be able to do that. I see that another one of the question is the problem is our current office. We have 4 hygienists, but not enough patients to be seen. They recently did end a contract, an insurance contract, which drastically reduced the patient load. And we're having issues with cancellations, failed appointments, also, like most offices are currently. And how do we as hygienists increase the patient seen and or production? I think that's a great question. And I would go back to looking at how many prophy codes are walked out. How many do you walk out with a prophy code? And looking at if we're spending an hour with them and we could literally keep right on scaling and it's been over 60 minutes, I would probably guess that we did some at least localized scaling and route planning on those patients, because we generally, most hygienists across the nation do throughout a prophy. And I think if that starts to happen, or based on our assessments, is maybe letting the doctor know in the morning, hey, can you come in at the beginning of the appointment and help with the diagnosis of this patient? I know they're on the schedule for prophy, but I looked back in the chart and they've been bleeding, you know, kind of like a Criminal Minds episode. The blood's on the ceiling, it's on the suction, it's everywhere. Can you come in at the beginning and sort of help me with the diagnosis? And really having the doctor support that. And I think that's really the team and the doctor offering up that respect as well too. And most doctors that I work with are always happy to help where they can with that. Dr. Mehta, did you want to weigh in?
Yeah, so getting in on that, oftentimes it's hard to, you think like, hey, if this person doesn't improve, I should diagnose this next time, but then that's never documented anywhere. And you forget, but the next time the patient comes in, and there they go, another 6 months with just a prophy. What we've done is we make mental notes of that and we put it in the appointment block as a note, and our software allows us to do that in their next appointment block. So when they set up their next prophy 6 months from now, I'll have like a little tag on that appointment saying patient had lots of bleeding last time, severe inflammation, evaluate for perio. And that in my morning huddle is an indication, hey, I need to come in and do that exam earlier than at the end of it, so I can diagnose this if it needs to be diagnosed. And my hygienists are able to add those tags as well. So if they notice that this is a more aggressive prophy, or I'm doing scaling, or perio numbers are looking pretty bad here, and historically this patient has got away with the prophy, let's go ahead and nip that in the butt and address it at this next visit so it doesn't slip through the cracks. A lot of the profitability in hygiene, I feel like, is it doesn't necessarily have to be like diagnosing more per patient. You have existing patients in your practice that are just falling through the cracks.
100%, totally agree. And we've been treating them for years, actually.
Right. We've also, for any of the practice leaders, office managers on the call here, I know that some of the offices we work with, they're helping train their hygienists on using the short fill list, or helping them make and text out for the patients that have had recent cancellations. Maybe if they're an SRP patient and they canceled, just think of how important it is we get them back for their overall health.
Yeah.
So having that hygienist make that phone call.
Let's do one last question. There's still a lot of people listening in. This has been really a great presentation. One of our biggest challenges is converting our existing patients who have been getting cleanings for years to scaling and route planning. I think this is a really good question. What tips do you have for increasing case acceptance of perio treatment for existing patients?
Well, I know for our office, and then I'll let the doctor answer as well too. I know for our office, the 4346 code, which is scaling in the presence of inflammation. For our existing patients, if we have been seeing them for prophies over and over and over again, sometimes we will use the scaling in the presence of inflammation so that we can say to the patient, we're going to go in, gently remove the bacteria. What we've been doing, trying to just see you every 6 months, may not be working for your overall health, as we're not seeing the outcome that we were hoping for. So let's go ahead and provide this medicated or therapeutic continual cleaning, whatever it is that you call it in your office. We usually call it a medicated therapy that we do with the patient. We do some irrigation, and then we do reappoint them and bring them back in probably about 6-8 weeks and check to see how they're doing. We definitely don't push them out for another 6 months, but we do have them come back sooner so that we can reevaluate. And then we say at that time, I know you're going to go home and take good care of this, and you're going to really improve what you're doing at home, but let's check it. Sometimes that may not be enough because the area might be too deep for you to clean at home. So let's bring you back. We'll check. We'll have doc come in and take a look as well too. If it still hasn't resolved, we might need to move in more of an aggressive approach to treating the disease. So let's see how that is. So the 4346 for us really helped with our existing patient base. Like Doctor said earlier, new patients are, they don't know what they don't know. So we can say you have an infection, and we can roll on and enroll them in treatment. With our existing patients, it's a little bit more difficult. We've found that helped us. But Doctor, what do you think?
Yeah, for existing patients, you kind of have to read the room. If somebody's receptive to you educating them on what perio is and showing them, hey, these are your charts from the last 7-8 visits. Look at the trend here. Something's not working for you. If they're receptive to that, great. Then half the battle's already won. If they aren't receptive to that, you can usually pick up on that with body language or verbiage that they're using, and tell them, look, if these numbers don't improve, it's confirmed that you have an active disease, which is what periodontal disease is, and an intervention is merited. I would hate to see you go down this path unchecked with me saying nothing, and then you end up losing teeth. We're not going to be friends at the end of that conversation. So let's, if they're hesitant, plant the seed, live to fight another day. Because that same patient is not going to, if they leave your practice, they're just going to go find the doc who's going to tell them, yeah, you don't have perio. I don't know what that quack before me was saying. And it's just going to continue, and that patient's never going to get treated, and eventually it's just going to end up them losing teeth. I'd rather plant the seed, know that they know I'm watching, them give their best effort to try and correct the issue at home with improved home care. In the off chance, you and I know that that is not going to work, more than likely, if the pocket is deep enough. If they come back, at least they know, hey, look, I tried, it didn't work, the numbers aren't improving. Let's go ahead and do this SRP. I want to keep my teeth.
Right. And I think just adding on, Mary talked about all the other, other oral systemic links in addition to the risk of losing their teeth, right? I think that's a lot of the messaging that we like to share with offices as well, is really bringing that home based on their medical history and what you're finding in there, if they're diabetic or, other things, and then linking that even together. Can be
yeah, sometimes they're even new diagnosis. I had a patient recently who came in and I hadn't seen her in about a year, but she had undergone chemotherapy, and it changed the whole, really the whole architecture of her periodontal condition. She was really, has great oral home care, but she actually came in and was struggling with so many other issues. But that's a health issue that it impacted her mouth as well, as most of them do. Same thing with patients who maybe, have undergone different types of medical issues like diabetes, or being diagnosed with that, or medication changes that do cause dry
Even
mouth.
pregnancy,
Yeah.
will influence it.
Yeah, pregnancy, absolutely. I was talking with someone this morning, and they were saying that one of the patients that they saw who is pregnant actually had a form that she brought in that the office filled out to ensure that she is receiving routine and regular hygiene care, because it does have the impact of the unborn baby, to your point, doctor. Yeah, absolutely.
Good. Before we break here, I want to plug Dental Education Partners. Again, Mary and Stephanie's company. They can be found at dentaleducationpartners.com. And then our sponsor, Care Credit. Thank you again, Care Credit, for sponsoring today's CE event. And then the Synergy Dental Partners, which is the group purchasing company. If you're interested in the Synergy Dental Partners, you can find us at the synergydentalpartners.com. And then all those that want to go work for Dr. Mehta, he's dentistry on the ponds, right, Dr. Mehta?
Dentistry on the ponds.
Dentistry on the ponds in a lovely town outside of Minneapolis.
Yep, Chanhassen, Minnesota.
Chanhassen, Minnesota. So again, you guys, Mary, Stephanie, Dr. Mehta, I think this was great. Thank you guys all for lending your expertise and your time, and I really appreciate it.
Thank you for having us, and
Thanks
thank you
for
so
having
many of you for spending your evening with us.
Thanks, everyone.
And-
Yeah, it's been a pleasure.
Yep. And thanks to all the participants, and thank you, Tori. Thanks, everybody.
Have a great night.